Cardiology, and for a lot of people, pediatric cardiology is a little different. It's very different than adult cardiology, and in its simplest form, we have children that are born, or in most complex form, with essentially half of a heart. And so it can take a series of surgeries to get their circulation to a point where it can sustain life. And so some of those surgeries can be quite complex, where we're trying to reroute blood flow through these convoluted pathways, and that requires the surgeon to know how to put the patch in. And as a congenital heart imager, it's my job to provide them with the best information so they're not surprised when they get inside the heart. And so for the years, ultrasound's probably our primary modality, and then 10, 15 years ago, cardiac MRI grew into our field and is now something that is essentially required to get the best information on complex cases, and CT as well, but MRI is used primarily. So even if we're looking at a 3D rendered heart on a 2D screen, it is still a 2D image that sits there and rotates. And so what 3D printing has allowed us to do is to pull that 3D image off the screen and into our hands. And now the surgeon can actually, look at the heart and inside the heart that he's going to operate on before surgery. A couple truths have become apparent that we must abide by. Number one, if we're going to be making medical decisions on these printed models, which has never really been done before, we have to make sure that we're improving our knowledge of these hearts and avoiding the pitfall of gaining a false understanding of the anatomy. And so when we segment the heart, we do it in a very specific manner that replicates the actual anatomy. We go through slice by slice and make sure that the model is going to represent the true anatomy. After we perform that and evaluate the heart and make the medical decisions, we always want to take it back to the source image where the information, where the model came from, and make sure that we can verify our understanding with that source image, so that we're not falling, into those pitfalls. And that is really, for me, just by printing the heart out on some of these complex cases, and once my level of understanding is improved, I can then go back in and reformat the 3D image to demonstrate what I need to know. And that's just, it's an amazing technology that we now have available to us, I think. And the very first patient we did this specific maneuver on was really just a proof of concept on a patient with a diagnosis that was similar to one that was coming up, where it was much more complex. And when I had to catch the surgeon before he ran into the OR and sit him down and have him look through the heart. And when he was looking through the heart, he said, "Oh yeah, this is fantastic. I can see exactly where the patch needs to go." But he said, "But what about the Swiss cheese VSD?" VSD is a hole in the heart, and there was an additional hole that is sort of known to evade detection by traditional methods, because with the larger hole, there's no pressure gradient driving the force across it. But it was his understanding of the 3D architecture of a Swiss cheese VSD that when he saw in 3D form, recognized that it was there. And this changes the surgery for this patient. And so, I was like, well, I don't know. I didn't, plan on that. You have to proceed as planned. But the first thing he did was he went in and confirmed that was there and then altered the surgery. So in that case, it saved ischemic time. The heart has to be down to get inside, and so it was down less because he confirmed it immediately and sort of went with the backup plan. But in the future, this is going to enable us to avoid, stopping the heart altogether in that sort of a scenario. And you have to ask yourself, what is the question? And what do I need to understand in this heart? And if it comes down to small venous structures, that we're probably not to that degree, but for the most part, we're dealing with the gross anatomy and understanding of the intricacies of the detail. I mean, we have multiple hearts. We have one from a 3.7 kilogram infant where we can see the papillary muscles and the moderator band and the trabeculations within the right ventricle. And so that's fairly high detail in a heart that sits in one hand. It's almost like the size of an egg. And so it's really transforming very quickly. And to me, the key component isn't so much what the end product looks like per se. The key element is taking it from an anatomic image to that digital representation or the digital model. Because the way printers are coming down in price and new printers are coming out every day, you can print it off on a million different printers and sort of vet out which one's going to have the resolution you need and be the detail you need. But it's not going to be any good if you don't have that accurate digital copy. And so from what we do with congenital hearts is sort of rendering soft tissue. And so that's what takes some practice and expertise. But when you're rendering bone, that's fairly easy. And so the level of software needed for bone, I mean, there are places that you could pull an old file out now and print it with existing technology where you can render it down on software that all hospitals probably have, and then you can ship it out to any number of vendors. I don't think investing in the printers themselves is where the investment will need to be made. It'll be in the expertise, the engineers, and the software to take it for especially the soft tissue structures.